thanks for coming down to 160 Studios all the way from the left coast.
Well, thank you for having me. I'm really happy to be here, and this is a fantastic city. I'm really thrilled to be talking to you today.
Thanks. Yeah, Dragonfly and 160 have made their mark in the med tech industry, much like Shifamed has.
Thank you. Well, you got to keep working at it, and you find different ways to do similar things and get better at it when you can. So,
I was out there during JP Morgan, and you took me on a tour, and I think we saw every single facility and product and met a bunch of the leaders. And you've constructed Shifamed in a very, very interesting way, which is relatively unique in the industry. So if you could, share the philosophy of the organization, then we'll cut into some of the properties particularly.
So for me, it's all about getting things done super efficiently. So we want to, as soon as we think of an idea, that we can immediately prototype it, build it. So I wanted to remove the burden of the basic infrastructure that you need in order to get started. So there is a permanent sort of central starting point in terms of facilities where we start all the companies. But as soon as a company is up and running, it gets its own facility and it is able to be autonomous. We like really small teams that are super mission focused, and we want them to mostly do the engineering work on their products. The products really is where it's at, and that's where the value is. Boston Scientific doesn't need to have more HR people, and Medtronic doesn't need more finance and accounting people. So the back office is centralized and shared resources across the portfolio, but the teams for each of the companies that are focused on their products, that's all they do. They're focused on that particular product, they're trying to get it to market, get it into the clinic, and they don't really have to worry about anything except their work activities and how they're going to get that product into humans.
And they're all in a centrally located campus. Like, we literally walked out the back door of one into the front door of another, and you hear about these incubators, accelerators who have these shared resources, shared 3D printer, shared extrusion machine, right? Shared firing ovens. But each of them were legitimately turnkey standalone for a J&J, an Abbott, a Boston Scientific to come in, purchase it, and have the keys the next day and run without any integration issues.
Yeah, this is a key thing for us. We'd rather have duplicate equipment, rooms, facilities, clean rooms, machine shops. That is what allows them to do what they need to do. When they set up something on the machine, on a CNC mill, to take it down for another user to use it for another company is a huge time wasted. And they can't really fine-tune things and sitting there trying to schedule machines. It's not what we're trying to optimize the use of machines. That's not the purpose. We want the machines to be there, to be used as much as needed, but everybody gets to set it up and leave it there. They don't have to worry about it. And that way they're efficient in their production. They can go and test something, come back, make a change, and they're up and running again. So we would rather duplicate facilities. And it's really critical, especially post-transaction. When you sell a company, typically, if you don't have the facilities, the space to support these people, you immediately need help from the large corporate that just acquired you. And when you do that, you sort of invite the opportunity for others to come and help you. But often they're not really helping, they're bringing their perspective, they want to bring you into their quality system perhaps, or they're trying to get to know who you are, what you are, and they're getting to know each other because usually they've been selected from a variety of different divisions and trying to make things happen. And the team that designed the product from the beginning often gets distracted, right? Now they're having to explain to people and different people all the time, various visitors that are coming to help, what needs to take place, how it works, how they built it, why they designed it the way they designed it, and so forth. And that's really very, very distracting. So what we're doing is set up a standalone facility that can really support that product and that team all the way through early commercialization, right? So they don't have to ever leave their building in terms of getting what they need done. They don't need to ask for support. People can support them. I'll give you the example. The last company that we sold, Nevera Medical, when J&J Biosense came to acquire us, we were only 29 people. We had a big clean room and big R&D facilities, arguably oversized. Within the next 2-3 years, they raised it. They ended up having over 100 people in the facility, a lot of assemblers. They expanded the clean room a little bit, and they were able to launch commercially from that building. And that was very successful. The team never really got too distracted. They were able to hit all their milestones. At the same time, Biosense set up its own facility, OUS, in a low-cost labor area that they're able to ramp up appropriately at the right time, in the right sort of pace that they needed to, for them to take the full production, larger scale production, for full commercialization. That to us is really the example of how to succeed. I saw this take place with Fred Kostravi a long time ago when we sold EPI to Boston. Fred really protected the organization. We were in a standalone building. We got into a different standalone building. We had our own assemblers and all that kind of stuff. And that really allowed that team to stay focused. We didn't get distracted. They established larger scale facilities later on in different places, but they didn't disrupt what was there. They didn't need to get too involved. That team was very productive. And those are the examples we're trying to follow, where that team, following the transaction, continues to be self-sufficient and as autonomous as reasonable. So they continue to deliver, and they don't get so distracted. I have examples where it didn't work, where we immediately had to get support from the large company, and hordes of people came to visit with us and help us, but the facilities were too small. And so the components in the system, the subsystems, were spread all over the world in different time zones. And that's really difficult for a small team, usually of a focused nature type people on a particular product, that now have to deal with a variety of different team members from all over the world trying to help. And that becomes, just trying to absorb the newcomers becomes a challenge and a huge time-consuming sort of aspect of what makes transitions very difficult.
And that's important for your shareholders, because you can hit your milestones if there's extended out milestones on there and they're not distracted. Yep. As you said, look, we need to harmonize. If I'm a J&J or a Medtronic or an Abbott, I've got a quality system I've got to harmonize and protect, understood, and a finance system. And we've seen this with these transactions. It slows down your ability to hit the milestones and then ultimately the payout. And these larger organizations want you to hit your milestones.
Everybody wants the milestones to be hit. And it matters to us, like you said, first we have payments associated with the milestones. But just as important, we have a reputation to uphold, right? We're not doing this once. Mm-hmm. This is not one-time thing. We have a brand to protect and promote, which is Shifamed. We want people to recognize that what we do is really the best that can be done, and then when they acquire from us, they're going to be successful. And so that's why we are setting up, thinking for the future. From the very beginning, we're thinking to build for success. And if we're able to resource properly, we can fundraise for the companies appropriately and provide them with what they need to be successful, not just in the first year or two, but really beyond that. That's really the key. And I think that's what makes a big difference in terms of ultimately successful transitions. And we've done them right, we've done them wrong, and I think we're learning now how best to do them. And that's kind of a current iteration of how we do things.
You've predominantly been in cardiovascular. There were transactions. You've raised, I think, about $400 million plus to date through Shifamed, right?
Yeah, actually more than that, but yes.
Yeah. And I think you've got about 350, 400 patents there as well. So obviously an innovation company, first and foremost. How do you decide on what to pursue? What markets do you look at? Do you have a thesis that is generally followed on this?
So what we're looking for really is emerging trends. We're looking for a scenario where when the team has accomplished what they intended to accomplish, they got the product in the clinic, they've designed it, they've shown the world that it works, that the world is ready to essentially work with this company, to acquire it, to invest in it, to take it to the next level. I think it's hard for us to scale, have multiple companies, if the companies are the first to do something, and that even though you may have gotten to the clinic, you still have to convince the world this is really worthwhile, that they should be interested, they should invest, and they should acquire. So for us, this is really critical, that from the beginning, we know who the likely acquirers are, that there's more than just one. that they're likely to be super interested in what's going on because it's essential to their business. So that to me is a foundation. There's a lot of different interesting things to build. I mean, we're engineers. We like gizmos and technology. So that you can find in so many different places. But I want to apply that skill set into areas where people are really compelled to do something about it within a short period of time, within the investment period, right? So it's hard for us to go for things that are going to be super important, but 10 years from now, or that we're too late and nobody's interested anymore. So that to us is really critical. Where is the new space that I know that as soon as we've sort of developed it and got it into the clinic, everybody's already on board, everybody's really interested in the space, everybody's looking at this. Also, it means that we're likely to have a lot of competitors, which I'm happy to have.
And so let me unpack that a little bit. So you're less interested in creating a market. You're waiting for a first mover to create that market. Then you'll look at that technology and say, how can we make it dramatically better? And make it dramatically better so if you do have a competitor, the competitors will be secondary to your technology for whatever reason. And then you don't intend on building a commercial team, because by the time you're going to take this to market, you get taken out because you've created so much value to any one of, let's say, 8 to 10 companies.
That's correct. That's correct. I mean, at some point, we'll probably commercialize our products. It's just a matter of time. At some point, that will take place. But our standard model today of what we want to accomplish is we want acquirers to be essentially looking and watching us, interacting with us, so that when we finally reach that point where the evidence is compelling and they don't want to wait anymore, they're able to go ahead and make an acquisition.
And that's an interesting model because it's moving closer to that emerging build-to-buy model. Again, that you're starting to see a big uptake in med tech, which has been in biotech for a long time. And it allows for more reasonable acquisition numbers because you're not looking to have to compound a 4x return on a dollar or a 5x return on a single dollar that is spent usually building out a sales team that's done inefficiently as you start to take a product to market. So it allows your investors to exit a little more quickly and has more likely acquirers sitting on the sidelines, not overpaying for something that was driving proven sales at a meaningful number.
Correct. When companies take a look at us, I want them to see us, okay, this fits right into, the sales bag for their distribution force, right? They're people that are targeting the different hospitals. They can just plug it right in to what they already have. That's really what we're aiming to do. Because building a sales force is a significant effort. Again, we're not, we're happy to do it at some point in time, but generally speaking, we would like for people to recognize the value that we've built, and to go ahead and make a move because it allows us to continue to do what we like to do and what we're best at doing, which is designing new products, new research and development activities that lead to difference in terms of outcomes for patients and physicians and so forth. So that's really our sweet spot. That's where we want to continue to do. And to the extent that people can see the value that we've created and decide to make a transaction, this is what we're looking to accomplish. So everything we've done is really about that. We can turn on a company and turn it off, switch it over to another owner in just a few days.
So who are the investors? Again, you've been very successful at raising. I think in 23, at least even in the last quarter, maybe you had a number of rounds that you raised, 30 million, 35 million, 40 million for a couple properties, Laza, Akura, right? Sapira,
Yep.
All had successful financing. What is your typical, if there is such a word, what does your investor look like? Who are they, where are they from, what's their typical interest?
Who they are matters less than sort of what their outlook is. So we like investors that are sort of see what we've done, appreciate what we're doing, and want to be part of the journey, right? And that are looking to hopefully invest in more than one company. If the formula works, apply it over and over again. So we're looking for people who are committed to a relationship over a longer period of time, so we can together take advantage of the first company, the second company, and the one after that, and after that. So that's really the kinds of relationships that we're interested in. So they're VCs, but they're also family offices or anybody else who has sort of that outlook, who understand what we're trying to do, who see the benefit of our model and how we accomplish things.
I'm seeing the family office become more and more present in the investment community these days. And I'll say this, I think the venture community has become a number of lemmings as they wait to see, and they don't want to be the first mover because they don't want to be wrong, but they also don't want to be last, so they're sort of stuck in that no man's land. But the family offices typically will invest and want that ongoing relationship, and that syndicate of family offices tend to talk to each other. And so that pull-through could be substantial as well. Are you finding the community like that at all?
It seems like it. I mean, I think we're starting to get some of those family offices reach out to us directly, which is great. And they certainly, once they know of each other, they'll start talking to each other. And I think, of course, naturally, they'll speak to their peers that are not involved with us. So we've seen this. We like it. We think it's great. Often, family offices have people who have successfully built and sold companies, and they know what it takes to build a company and be successful. So when they come to see our facilities, they talk to us and they sort of appreciate the culture. Often it's very similar to what they've done. And they see a resemblance or see a sort of a parallel of their history versus what's in front of them when they talk to our CEOs and team members and see the technology that's being developed. They see the passion, they see the deep technical expertise. These folks have not just done a bunch of random things. Often they've built, with deep knowledge in their sector, been very successful at it. And they see how we know our space intensely, very deeply, and are super passionate about what we do. And it reflects in the products and the quality of the products that are coming out, and the innovation that comes out.
So it's like the old days. It's like the investors were actually previously operators. So they know when they see it, they're like, okay, this works, or hey, I can offer some advice if you want it. Of course, medtech's a little different with a nuance in it, but an operator's an operator. An operator sees another operator.
That's right.
Where today, venture, maybe not so much. I saw an interview recently with Khosla, and he said, anyone out of my investment team who's never run an operation before is not allowed to give a CEO advice. They have no right giving a CEO advice unless they've been an operator themselves. And going back to the old days, I want to go back to your resume a little bit because I think it's pertinent to our conversation. You came out of early days ACS and then cardiothoracic systems. I mean, those were the on pump, off pump. ACS is one of those you can carbon date most really good engineers back to that ACS days. And then CTSI, and that battle between CTSI and Stanford Surgical back in the days.
That's right.
Right? The old Rich Ferrari fight was going on during those days. So tell me a little bit about your experience. You came up as an engineer as well.
Yeah, I mean, so ACS was an amazing experience for, I can't think of anybody who doesn't sort of agree with those statements of things were happening fast, products were being released, with a year and a half.
Late
apart.
80s, right? Late 80s.
Late 80s,
Yeah.
Early 90s.
Yeah.
It was the beginning of the industry. And all the best people often went to start new companies. And so you got a sense of, ultimately, I want to be one of those best people and start my own. So that sort of put in you that idea that you should start your own. Look, the success is, you know who's succeeded and how they've done it, or at least you've spoken to them. So you felt compelled that you could maybe try yourself. The mindset and the culture was really what I think it's come through in all the other companies that have followed, right? Competency and people really being promoted for doing good work. And then also a variety of people being involved. Nobody felt like it was just one group versus the other and so forth. So and they were very generous in the education they gave us. They had the monies, they were well supported, but there was also a lot of excitement. Patients were being treated, lots of them. So it was an amazing period for all of us who went through that. And then it was the beginning of the stent sort of era. I left about the time when it was still early days, but it was already sort of being developed. And that was, again, we all felt like we were changing the world as you're participating in ACS. So a lot of what I've done since, and a lot of us, what we've done is emulating a little bit of that culture. Then CTS. CTS was a startup at the time when I joined. I was, third engineer to be hired. And it was super exciting, right? I got to get close to Rich Ferrari, and it's fascinating to watch somebody like Rich operate. And so being very close to the leadership like this in a very small organization at the beginning, and then see the change take place, 1 month at a time. It was dramatic. And ultimately we went public. And that was what a ride that was. So all of those things sort of gave me the impetus and the cultural sort of reserve to move forward and try to do something similar, trying to emulate what I learned from those experiences.
Yeah. And each of the companies that you've got going now, you've gone outside of cardiology a little bit. You've got some ophthalmology play. You've got a software play. I want to talk a little bit about what my friend Pablo is doing with you. I'm really excited about that. So take us through the portfolio, if you would, of the organizations, and if you wouldn't mind stopping off on each of them, what's unique about them and why the market should care.
Sure. So we have 5 cardiovascular companies, 2 ophthalmology companies, and an enterprise software solution. So the cardiovascular portfolio, we have a Superior Medical with a percutaneous heart pump. Super exciting product. Abiomed sort of paved the way in this space, been extremely successful. Huge number of patients being treated, patient lives being saved, great revenue numbers, and an ultimate acquisition by J&J that was, outstanding. So we're trying to be in the same space. We think we have a really compelling product. We think we're a second-generation product with significant differences. There's other players in this space, but I think there's not that many that are, as far along as we are. It's very exciting, right? We've treated 55 patients so far. The physicians are totally excited to use the product. It's one of those situations, the product is used during high-risk PCI cases. So when they put our device in, they put it in and then leave it and they forget about it, which is the best thing you can say for this kind of product. They can treat their patient, even if things are going bad or the patient heart stops. No problem. The pump is running. Patient doesn't even know that that's happened. They get treated completely, perfectly the way that the physician wants to. And then ultimately they can remove the pump at the end of the procedure. It's an amazing kind of a product. There's other indications for cardiogenic shock that we're hoping to get into at some point in the future. We're very excited about that. This was not an easy effort. It took a lot of money, a lot of serious engineering to take place, a lot of computational, CFD activities. So it was a big effort. We learned a lot. There were some, painful and, moments, as you know, in the ups and downs of new designs coming to being. But right now, the product under the leadership of Nitin Salunki has been doing really a great job. Our sites in Brazil, have been amazing. They've been generating a lot of patients, a lot of really modeling the kind of patients we will be treating in the U.S., really high-risk patients, they're really sick patients. And the products have been doing really well. So we're super excited about this.
Tell me about LASA with Pablo.
Sure. So LASA is a sort of a different solution. So we're not in the bloodstream, but we're guiding procedures in the bloodstream. So these are cardiovascular procedures that need to be guided by ultrasound. So as you know, when you start treating patients in the chambers of the heart, the atria and the ventricle, you can't really fill the heart with contrast and see what's going on. The patient wouldn't survive that. So you have to use ultrasound. And ultrasound is used in 2 ways, either through a transesophageal probe down your mouth and in your esophagus and looking at the heart, or intracardiac Echo, ICE, which is the company that we sold recently to Biosense Webster. Right now, we're focused on the TE. And today, when you're doing this procedure, that product is used by echocardiologists, so very experienced specialist who happens to have also certain skills of being able to interpret ultrasound images and understand where they are in 3D space. Not a lot of people can do this. Not a lot of people can do this effectively. And they're also very, they're standing, holding, and every once in a while they move the probe and adjust the knobs and so forth. So it's not easy for them, and yet they're not really the main sort of physician who's treating the patient. They're really an assistant, but they're critical assistant. If they don't do a good job, the procedure doesn't go well, no matter how good the interventional cardiologist is, who's doing the procedure. So what we're doing here for this solution is really automating all of that. So we want the really good echocardiologist not to do one procedure, do multiple at the same time. They don't have to be in the room. So the burdensome part of holding and moving and getting cramps and being really close to the C-arm and being exposed to X-ray, all of that sort of goes away. And they can direct the robot and modify certain things about what we're looking at in terms of
remotely.
Remotely, yes. And there's a certain intelligence to the system because it's not just moving the probe around. It's actually displaying the heart in its totality in 3D in real time. This is really the key thing. So the physician everybody in the room, not just the interventionalist, but everybody can understand what's taking place. The physician knows exactly what they're looking at, and they know where it is relative to other anatomical landmark of the heart, and they can see the devices they're moving around. So this is really, it's the future, and we're absolutely certain of it. It's like in the old days, when you start using C-arms in a cath lab, you had somebody that moved the C-arm around just to get the different angles. And eventually, very quickly, you automated it with a joystick. This is the kind of thing we're talking about. Nobody has to constantly try to go from one position to the other and not sure if they got the right position exactly. It's really hard to, remember exactly where you were in 3D space while you're moving the probe around and understand what you're looking at and so forth if you're not so skilled. If you're really skilled, those things are not so hard. But not everybody has that, and not as many people as you'd like go through the pain and process of getting those additional training and degrees and certifications to be an echocardiologist. So we want the guys who are really good to spread their knowledge, help others, and be able to do multiple procedures at the same time. Typically, these physicians are not being compensated by the procedure. The hospital has to pay out of pocket to make sure that these procedures take place. They're not part of, the DRG doesn't account for them. Mm-hmm. So there's also a reimbursement issue. What we're solving is fundamentally a labor shortage of the skilled, capable physicians that do this procedure today.
Yeah, labor and competency, because it sounds like you could accelerate competency dramatically, which is what robotics does.
Yes.
In any procedure, right? You can accelerate that to that level of competence way quicker, and also it's an unlock for more procedures.
Absolutely. And the key is the robotic piece is actually the smaller part. What matters is the feedback mechanism of the system that recognizes this is this anatomy, I got to go from this angle. There's a shadow here, I can go from the other side. Mm-hmm. The better angle to do the transeptal is this way. You can indicate that for the physician. So the knowledge and the appreciation of the anatomy and the devices and the interaction of these things is really what's important here. It's not just I've automated the movement of with a joystick of the TE probe. That's not it. Mm-hmm. It's really the understanding of, to avoid this issue, I've gone through the various scenarios. I'm speaking on behalf of, let's say, the robot. So therefore, this angle is the preferred angle, or this view is the better view. So we're not going to take anything away. The physicians will have all the same images they've historically had, but we're going to give them a lot more that they've never had before.
Does this remove the imaging tech out of the room?
Yeah, they don't have to be there, really.
Okay.
The interventional cardiologist, once the expert puts in the system, pushes the button, and the system, the robot, will go ahead and image the whole heart. They'll verify that everything is okay. So they're still really important. Certainly at the beginning of the procedure, make sure everything is set right. But then they can leave the room. And the rest of the procedure can be done with an interventional cardiologist saying, give me 4-chamber view, give me 2-chamber view, give me this other view that we talked about, and he can speak to it or do a touch, a touchpad display, touch where you want to go and so forth. But the echocardiologist can go to his office, do other procedures, but they can monitor multiple procedures at the same time. They can intervene remotely if they need to. They can go back into the room if they have to, do whatever they need to do. And the system can immediately go back to being a manually driven system. So the safety is always there. You're always able to do what you normally historically able to do. You just have these additional capabilities.
Fascinating. What else do we have in there on the cardiology side that is exciting? Cora?
Yeah, Acura is we think, I'm calling it sort of the digital thrombectomy solution. So we have a really good engine mechanism for removing the clot. So what we've learned through what others have done, like Inari, is like a large diameter gives you a lot of aspiration force, a lot of force to pull the clot inside the catheter because the diameter is large. It's basic physics. So we have a very large sort of entrance to where we capture the clot, which is at the end of a funnel. But at the bottom of the funnel, we have water jets, not one, but multiples. As the blood clot reaches that area, it gets broken up into smaller pieces, and it goes down the catheter. Now, the catheter shaft ends up being small, which makes it for much easier delivery. The other thing that's really critical and different about our system is because we are a really small profile, with a funnel that pops open, we can use a steerable sheath. Now, the steerable sheath is a basic system, but most systems out there are really trying to optimize the large diameter of the shaft, which precludes them from being able to use a steerable sheath. So we've solved the problem of large diameter, certainly in the delivery part, allows us to use a steerable sheath, which allows the physicians to do a dye injection. They can do a small puff of dye to visualize where the clot is. And so we also have added a pressure sensor. Today, when you do these procedures, you do the best you can. Sometimes you get stuck, you have a piece of clot at the end of it, and you can't really evacuate it properly. You have to remove the system altogether and so forth. So first, we solve that problem. It's like we never get stuck. Our system is always able to remove everything, no matter how big it is, and go, well, because you have a steerable sheath, you can steer into another branch and go down and get some more. But then there's a point in time, which today is not that information. So how do you know if the procedure is done? Are you done with the procedure? How do you know that? Today, it's a bit of gut feel. The experienced physicians know they do as much as they need to, and they stop, because if doing too much can also harm the patient. So what we have added is a pressure sensor. So not only is the steerable sheath allows you to steer, it's very flexible and soft, so you can cross the two valves to get to the lungs, and you can do the dye injection, but it also has the pressure sensor, so that throughout the procedure, for a particular branch, you know exactly how it changed, how much the pressure went down. And that's really important and helpful, because then when you do that, you know, okay, I've treated this area, I can go and treat another area. So we're trying to create, and there's other things I can't talk about, right, that we've added to the system that really speak to the digital aspect that's really important, that we will disclose over the next year or so. But we're one of the last groups to start working on this effort, right, trying to come up with a second generation product. And we said to ourselves, we have to do the best job possible. We can't sit there, move forward with the company and have somebody else supersede us. And instead of just focusing on one problem, we were not satisfied with the best clot removal, that doesn't require exchanges. That was not enough. What's important is really think through all the steps, pre-procedure, during the procedure, and post-procedure. What can you do for that patient? What can you do for the physician in the system to really, make a difference? These are very difficult patients. Usually when you're treating these patients, you're saving their lives. We've already seen that in some of the cases that we've done. It's very exciting, and what we're realizing is, and again, the Penumbra, Inari, and others have sort of led the way. But as you treat more patients, you're finding there's more and more being treated, And now there's a shift in how physicians are treating and thinking about these patients and what they consider dangerous and not dangerous. And they're realizing that it's better to treat earlier and remove the stuff with the best technology available, as opposed to just letting them be treated medically in a very conservative sort of way, which is not as good, now been demonstrated, not as good as was done in the past.
What other properties do we have? You mentioned the ophthalmology side of things.
So we have a couple of really interesting companies in accommodating intraocular lens called Atia Vision. This is a product that basically restores your vision the way you were when you were a kid, right? So today, so many people have cataract surgery. It's probably one of the most commonly done surgeries in the world. If you get old enough, typically you will need your lenses replaced. That's called cataract. And when you do, you typically get either a monofocal lens or bifocal or trifocal. And the problem with these are the depth of focus is discrete. It's either one or multiple. And that means you have to put glasses. If you do a trifocal lens, you don't necessarily need glasses, but you compromise on other things. You have side effects from the trifocal lenses, aberrations, halos at night, and so forth. And contrast is is diminished because of these products. So what we're trying to do is really allow the brain to behave the way it normally expects a lens to be, which is the ciliary muscles are activated by your brain to change the depth of focus. So without having to have glasses, you'll stretch and squeeze these muscles to change the curvature of that lens continuously from nearsighted, medium distance, and then long range, long distance. And so the system adjusts a little bit. Now, there are challenges about how you get claims for this, and accommodation is a difficult thing to prove, and so forth. So those are regulatory things we'll have to work through. But the fact is, what we've seen with our patients, and we've treated over 70 eyes so far, and after 2 years, the patients continue to get better. What we've realized and learned is some of those patients that we've treated had not been very active in reading really close and so forth. Once they get our lens, they start doing these things, and they're starting to get back the old muscle, essentially, the old muscle and muscle memory. So that's one of the ophthalmology companies we're very excited about. The second ophthalmology company is called Myra Vision. And Myra is a glaucoma product. So this is treating patients who have glaucoma. There's excess pressure in the eye, you got to drain it. And today, it's being drained by using small tubes, really, really small tubes or shunts. The problem with those is if you drain too much, you get hypotony and you really damage the eye. It's worse than the problem you started with. So you have to be conservative. You got to drain it, but not too much, which means to protect the safety of the patient, you're often not getting the effectiveness. You overcompensate because you don't know which patient is going to drain more than you anticipated and get into a problem. So what we've done is created a shunt that actually is adjustable flow. So after you've implanted in the patient, you can come back in an office-based visit, shoot a quick laser, and open a channel or close a channel. It's got 3 different channels. So one which is small, one with medium, and one with high flow. You can open all 3 of them. You can close 2 out of the 3. You can close one versus the other, and so forth. So you have 4 different settings.
So you can tune it with the laser.
With a laser, you can basically shoot a couple of milliseconds, and it turn on a channel and turn off a channel. That's leveraging memory shape alloy called nitinol, as we all know it. But instead of using the super elastic properties like you typically see in stents and frames for valves and so forth, here we're really taking advantage of the memory part of shape memory, which is related to the temperature. So what the laser is doing is really heating up for milliseconds an element which it allows a valve to open and to close. And this could be done literally in just a few minutes. And the patient can walk out with higher flow or lower flow, depending on what their physician determined was needed for them. And we've treated I think 28 patients at this point, and the data is starting to look really compelling. We're very excited about it.
And you mentioned finally an enterprise software technology, and that's a new one for you, though.
It is. So this is really, as we started to become more mature as an organization, Shifamed started focused first on accounting, right? Get the accounting system right and make it a shared resources across the portfolio. Get a professional CFO, get a professional controller, so you're not having to, okay, let's get a part-time CFO here, part-time this. So establish a system and a standard template for how you do your reporting, your financials, and do it across the portfolio. Then we did human resources, and Debbie was hired, and really she established the system, the thought process of how you hire, and all the right rigorous things that to create the right culture and retain the right talent and so forth. At some point in time, the elephant in the room is, what do you do about your quality system, your manufacturing system, your procurement and so forth. And what we had learned is do not create one system for all, right? We don't want to really force each company to use one system. We did that once at one point for Shifamed. We had a quality system that was ISO certified, but we quickly realized that it became good enough for a commercial organization, but really was detrimental to the early companies that were barely doing animal studies or not even. And yet they already had the burden of a full quality system. It was just not appropriate for them. So we started becoming more like a large company, which slows you down. So we abandoned that idea. And instead of essentially creating one system for all, we focus on the technology. So the concept here is we create a cloud-based tool that does everything that early startup all the way to commercialization company does. So this product will do your procurement, your POs, your receiving, will do your inventory, will do the manufacturing, all your documents will be there, document control is there, requirements tracing for all the different standards we have to follow. So all of these things are part of that system because all of these things need to be linked. So you have to have a database for all these things. And that is what we've built. The idea is that we can take and assist our portfolio companies and others with various templates. Each company has different set of requirements. Their SOPs are going to be different. But they don't have to have 5 ways to do POs. They can change things within and create different ways to do POs, but the fundamentals are not really any different. They can have a different template. So a lot of the changes in our system are really designed to be done by an administrator, not really a program. They can change templates, and any of the processes that are being provided by our system can accommodate.
And it can scale as that organization grows out.
Exactly.
Its capabilities, its supply chain, its supply base, all of it scales out.
Exactly.
But it was a homegrown product first.
Because none existed. It was not possible for us to go and talk to Oracle or NetSuite or SAP and say, hey, build us a system. I mean, they wouldn't even talk to us. We couldn't afford to spend just the amount of homework to figure out what we want to do, let alone build it. It's not practical or even reasonable to expect smaller companies to engage in that kind of an effort. But yet the rules and the requirements apply to us no different than they apply to the big companies. Yeah. So we had to create that. And then once we realized that's what we needed, we realized that everybody else needs it. And so we created a company out of it. And that's that's the big effort called NDEAL.
And pressure tested within Shifamed, which is
That's
cool.
right. Yeah, I mean, it's kind of the advantage. We already have, 8 companies that are using it. So we're practicing, improving it. And our internal companies you would think would be easy. They're not. They're just as demanding if they were external customers. And we continue to evolve the system.
Yeah. So as you come out of 2023, we're into 2024 now. What are you watching in the industry? What are you watching on the financial horizon? And thoughts as we roll through 24 and into 25 now?
Well, there's a lot of things that are happening relative certainly to machine learning and AI that you have to pay attention to. So that's clear. But also, a lot of what our industry does have to do, it's not all just about machine learning to do what? Ultimately, you have to intervene on somebody. So the skills that we've learned and developed over the years of how to deal with such a thing, be it a temporary implant invasive product or a full implant, you cannot put that aside. I mean, we've seen newcomers come to our industry and fail because they didn't know some of the basics of what it takes to deal with the FDA, to deal with the CE mark, how to build a proper sort of quality system and so forth. So you cannot essentially put that together. You cannot ignore the AI side of it. You have to do all of these things. So to me, at least certainly what we're trying to do at Shifamed is really be on the convergence of all of these things, right? So we want to be digitally enabled. Like if we're going to bring a new product to the market today and spend the money and time and effort to make it an invasive product, because the burden is increasing, not decreasing, and it's dramatic, and it's a huge barrier to entry, but we have to navigate it. If you spend all that money and time bringing that product to go inside a patient, you better have some way of digitizing it, a pressure sensor or another kind of a sensor, or some ability to take advantage of some of those tools that today are available to us that there weren't before. You have to think about that. You have to think about the machine learning side. You know, is there a way for us to take advantage of these capabilities? Usually there is, because this is such an enabling technology. From the patient to the physician to the how you produce it, everywhere you look, there's a way to take advantage of that. So you have to enable this. You have to put the right structure to take advantage of it, right? There's a lot of rules to follow, and they're growing dramatically and quickly. And again, this is where the Enlil solution is helping us, because once you create a template, you create an SOP, you have a way to do it, others can benefit from it.
FDA is changing guidance on it on a daily basis as well.
Yeah. So you have to have tools that help you manage these things. So that's fundamental. The invasive stuff you have to do, the AI stuff to do. I want to be in an intersection of these things, because I think this is where you're going to advance the cause fastest and best. You cannot just say, I'm going to just do this part. Even if you have a full implant that is purely mechanical device, enrolling patients requires technology, requires electronic data forms, requires machine learning to identify which patient fits, or maybe the follow-up of the patient. So to me, if there's a way for us to use the sensors, use the cloud, still have the invasive device and the advantage of those, because you're intervening on patients, that's really where I think the future is for us. It's all of these things together.
2024, what are you going to be undertaking? You've got 7 companies in your portfolio?
8.
8? Yep. 8 companies in the portfolio. What does it look like for you? What is the outside investment community? What should they know about where Shifamed is today and where their opportunities are?
I think they just have to look at the kind of products that we're developing and how important they are and how sort of life-changing they are. They can track the progress that we're making. Today, the portfolio is in a sort of a more mature stage. We did start a company last year that's still early, won't be in the clinic until next year. But the rest of the portfolio, all the companies are in the clinic, the ones that have a product that goes to the clinic. So we have 4 companies in the clinic today. The 2 ophthalmology companies are in the clinic, and the 2 cardiology companies we discussed are also in the clinic. Soon, Thyroid Cardiovascular, which is a mitral valve replacement company, is going to be in the clinic in just the next couple of months. So we're very excited about that. It'll be first in humans. We put a huge effort in a really sophisticated system that we think is going to be a significant differentiator and a solution for mitral valve replacement. And a few months later, Adona Medical, which is a heart failure implant, which is unique in its way. It's a shunt, but it's adjustable. So there's the advantage there. But on top of it, I'm following what I was describing earlier. It's got 2 pressure sensors, one on the left side, one on the right side, that are battery powered, right? Which is today doesn't exist. Today, if you want to take a measurement of your heart, the current products that exist, you have to put a wand against your chest to take a recording. Well, patients, we notoriously, especially older, sicker patients, compliance is a problem. They don't always do that. So what we've done is we created this product so that it's automatically taking readings throughout the day and night and uploading it to the cloud at night. So you will know what's going on with your patient. Again, machine learning is going to come into this and alert the physicians, this patient is on the wrong trajectory. Right. Okay, you may want to change the drug regimen, You may go back for a re-intervention of some kind, change the size of the shunt, perhaps, and so forth. So we're trying to really be the next generation of how you would want to treat a patient with all the different technologies that were not available until recently, and now are coming into play. So that's the company that will also be in the clinic today. So I think if somebody's interested in what we're doing, or take a look at the products and what they do and how impactful they could be. That's my recommendation.
Well, you've got your hands full with really exciting things. And I really appreciate you coming in here to Delray to 160 Studios to visit with us today and share the story.
Well, thank you, Joe. Really appreciate being here with you, and really, you know, your intelligent questions. You're really well versed in the industry. It's very a pleasure really to talk to you and share the stage with you.
Thank you so much. I'm Joe Mullings from 160 Studios. Be well.